Maybe Dr. Mayang, if you want to make a photo first before still have 1 or 2 minutes time.
Oh, okay. Yes, we can do that.
Dr. Yi Yun Chang, please open
Dr.
your
Ji Yun
video.
Chang, while we wait, while everyone's still here. Yes. Okay, Dr. Nico, we can please take the picture.
Okay, I will take the picture in. Please hold for 3 seconds because there are lag in connection. 3, 2, 1. Okay, maybe one more time. Okay, one more time. 3, 2, and 1. Okay, beautiful. Thank you.
Thank you.
It's already 100.
Yes, please, Dr. Siwang Lee, if you would like to start.
Okay.
Maybe wait for another 5 minutes or so, or 1 or 2 minutes, because it is registered more than 300, right?
Good.
Yes.
How is it, Tomo? Wait for 5 minutes. Yeah.
It's up to you.
Wait for
we could
5
wait
minutes.
for
Yeah,
a few minutes.
you
Maybe.
see that the number of participants is increasing.
Okay. Yeah. I mean, it's all up to Siwang too. So.
Miriam is there. Hi, Miriam.
I think we'll just wait for another minute and start on 6:03. There are about over 120 participants.
ಇವರು ರಾಜ್ಪುರೆ ಸೆಕ್ರೆಟರಿ ಹೇಳ್ಬಿಡು ನಾನು ಯಾವುದೋ ವೆಬಿನಾರ್ನಲ್ಲಿ ಇದನ್ನು ಫೋನ್ ಮಾಡಿದ್ರು ಐ ವಿಲ್ ಟಾಕ್.
Hi, Miriam. Another 2 minutes.
Okay.
So we start 16:05.
Okay.
Your command.
Approximately 140 participants. So maybe we'll wait for another 2 minutes.
Yes.
Okay.
Oh.
Dr. Yongbae Kim is connected. Hello.
Hi. Good afternoon, everybody.
Good afternoon.
Good afternoon.
Hello.
Hello.
Actually, Dr. Kim, Yongbae Kim is my boss, and in case of my computer shut down accidentally, I just connected with another notebook PC just in case of emergency situation. Yeah.
Okay, so there are more than 150 participants. Is that about how many people are pre-registered?
Mayang, how many is registered? More than 300 the last time?
Yes, I believe so. Maybe Dr. Nico would have the exact
Dr.
number.
Nico, the last number registration participant, how many? Nico?
Okay, Prof, I'm checking right now. Currently there is 505 participants already registered for this
400.
webinar. 505.
500.
500.
Oh, okay.
That's great.
And the participants are still fill the questionnaire. Is it right?
Yes.
I think the number's going close to 150. So it may be a good time to start.
Okay.
Hello, Sham.
Hi, Sham.
Hi.
Hi, nice to see everybody.
Hi, Sham.
Hi.
Okay, we can start. Maybe it's already almost.
Okay, then I'll start. Okay, do I start now?
Yeah.
Okay.
Yes, please.
Okay. Hello, everyone. Welcome to the 6th Faro webinar. I'm Siwon Lee from Catholic Medical Center, Korea. I am also a member of the Faro Education and Training Committee and will be moderating the meeting today. I would like to begin the webinar by introducing Dr. Ramesh Bili Malka from India, the former Vice President of Faro, to whom we owe the honor of opening the webinar with greetings. Dr. Bili Malka, please.
Oh, yes. Thank you. Thank you so much. Good afternoon. To some people, it's a good evening too. And welcome to our delegates and who are attending and our members of Faro. And just to give you the a background, our Faro is a very young organization, just 6 years old, and and 7th year running. But the activities of Faro is quite galloping day by day and year by year, and it is doing very well. And this seminar or webinar is very well planned. I know in this pandemic of COVID, and so far we have completed 5, and the 6th one is the one that's running now. And starting and from the first one was on 25th September. And we had, and second also was on 9th of October, we had on a COVID and RT, that was a situation of RT. We took a stock of all the countries and moved over to the 3rd, 4th, and the 5th, and with various good topics and which was covered. And every time, and the number of attendees are increasing, and that only shows the interest of our members and the content of the webinars and we are having. This time, the very rightly chosen topic is the breast cancer and what is the latest, and particularly in the present decade, and how the IMRT has changed the role of radiation in the treatment of a cancer of breast. And we have a good speakers and a panelists, and which will be moderated. And I wish this webinar all the success. I'm very happy to know that 500 people have already registered and for this webinar. Thank you so much.
Thank you, Dr. Bili Malka. Next, I would like to introduce Dr. Sung-Hwan Kim, the President of Korean Society for Radiation Oncology, for greetings from Korea. Dr. Kim, please.
Hi. Hello, everyone. I'm Sung-Hwan Kim, the President of Korean Society. I would like to express warmest greetings to all of you members of Faro. As we all know, Faro is a non-profit and scientific organization which aims to improve the basic level of radiotherapy for the benefit of cancer patients in the Asian region. I think that this monthly webinar is an excellent chance to academically sharpen your expertise in field of radiation oncology, of which why I am extremely glad to host the webinar on such a nice day on May as today. I would like to thank all of you for participating in the webinar despite your busy schedule, since your presence is what gives life to this evening. It is all the more meaningful that the monthly webinar is become a new tradition in the midst of COVID-19 era, which signifies the strength of unity and the ensuing brightest future in the field of radiation oncology in Asia. I would like to thank to the Indonesian Radiation Oncology Society for providing us with the platform of this meeting, not only with technical support, but also with thorough and experienced organization of the webinar through Dr. Pomata in particular. I'm also grateful to Dr. Tamaki from Faro Secretariat, as well as the education and the training committee members who beautifully orchestrated this evening or afternoon meeting. We are honored to the Dr. Ji-Seok Jang, the speaker, and the expert panel comprised of the most qualified panelists, not only from Korea, but also from India and Japan. I appreciate their willingness to gladly share their expertise with all. Breast cancer is one of the most commonly encountered cancer for radiation oncologists worldwide. In the era of personalized medicine as today, IMRT is another important tool which tailors radiation beam in conformity with patient-specific anatomy. Application of new techniques such as hypofractionation is one of the major assignments for radiation oncologists. I hope that newest finding in the field of radiation therapy for breast cancer covered in speech and the wealth of experience from the panelists will push your knowledge and further enhance your expertise. I also anticipate that this meeting gives opportunity to discuss the most debated issue in field of breast radiotherapy. Please enjoy. Thank you very much.
Thank you, Dr. Kim. Now I'll invite our speaker for the awaited lecture, Dr. Ji-Seok Chang. He is a professor in Yonsei University College of Medicine, Gangnam Severance Hospital. Dr. Chang is one of the most active radiation oncologists in Korea with expertise in breast cancer with countless publications. Whenever there's a conference on breast cancer, you'll find Dr. Chang giving a lecture there. So during the past Education and Training Committee meeting, when the May webinar was decided to be hosted by COSRO, Dr. Chang was the first speaker to come up on my mind, and luckily he generously accepted to give a speech today. It's my pleasure to introduce Dr. Ji-Seok Chang. Dr. Chang, please.
Thank you so much. It is an honor to be here on behalf of my colleagues, and I'm Ji-Seok Chang, currently working at Gangnam Severance Hospital. But today I'm going to talk about the previous works, which was mainly done at Yonsei Cancer Center. So these are my disclosures, and I had patents for auto-segmentations for breast cancer from Oncosoft and QualineSoft, and I had a medical consultant for Accuray. So today's talk, I would like to summarize the history and emerging evidences around breast cancer radiotherapy first. And at the same time, I will introduce how we implement these changes and evidence into our daily practice to optimize patient outcome. As you all know, breast conservation for early stage breast cancer is one of the remarkable achievements of modern cancer care. Numerous randomized clinical trials, including Milano, NSABP-B6, EORTC, and DBCG82M, which was initiated 30 years ago, have reported 20-year long-term durable results, documenting that survival is at least equivalent to mastectomy when the breast is conserved with wide excision followed by whole breast radiotherapy. In the 4 largest old landmark clinical trials I have mentioned in the previous slides, the whole breast was consistently treated with 50 gray over 25 fractions. And according to these trials, the local regional tumor control was expected as followings, and the acute and late toxicity of this conventional treatment was mostly acceptable in most cases. However, the problem is the burden of the protracted radiotherapy delivery, like 5 to 7 weeks of treatment, has been considerable. So, and the desire to reduce the burden of radiotherapy led to investigating alternatives. In the 1980s, Canadian radiation biologists first suggested breast cancer might have relatively lower alpha-beta ratio than other malignancies, and it stimulated the UK interest and subsequently Canada's interest as well, so that this finding were put to test in the clinical trial setting. In START pilot and START A trials, the choice of 13 fractions purely, which was practical, and this study design allowed to directly estimate alpha-beta ratio for adverse effect and tumor control by interpolations. Then subsequently, 15 fraction or 16 fraction in UK START B and Canadian trial was tested. And the next dose level was 5 fractions in FAST and FAST-forward trial. Like the first 13 fraction schedules, the 3-week 15 fraction regimen, which was designed by Pattinson from Manchester, was led to great success in UK START B trial, and which is adopted as UK standard of care in 2009. And more than 90% of breast cancer in UK received this regimen until recently. In Canada, 42 gray in 16 fraction was tested in clinical trial, and with the success of this trial also, more than 70% of patients in Ontario in Canada received this regimen since 2010 ASCO presentation. And this is the tables that summarize all the hypofractionation randomized landmark trials from UK START pilot to UK fast forward. And as you can see, all trials showed non-inferior or similar local control data. But in terms of long-term toxicity, some regimens show similar long-term toxicity, some regimens show decrease, and some other regimens showed increased long-term toxicity. And assuming alpha-beta ratio for late adverse effect, 40 gray in 15 fractions which is equivalent to 45 gray in 2 gray fractions. In other words, this regimen is gentler and late reacting normal tissues than 50 gray conventional fractions with a hazard ratio of 0.8, and marked adverse effects were reported in these 2 trials, DBCG Hypo and UK START B trials. And after these landmark trials publications, in recent survey from 44 European countries, hypofractionation was chosen for whole breast radiation by 55% and for regional radiation by 30%. And interestingly, radiation oncologists working in academic centers or practicing in Western Europe more likely preferred hypofractionations. And furthermore, the international expert report was published and endorsed the statement that there is no radiobiological reason why post-mastectomy radiation or regional node radiation patients should have different outcomes to hypofractionations. What about the atmosphere in the United States? And use of hypofractionation is relatively low in the 2010, early 2010s. And use of hypofractionation is steadily increasing in whole breast radiations. And you can see in 2015, the 50-50% use hypo and conventional. But in post-mastectomy radiation and reconstruction setting or regional node setting, still conventional fractionation is recommended in NCCN guideline. And currently ongoing alliance trial, A221505, recruiting patients to specifically evaluate the impact of hypofractionation in this clinical trial, in this clinical setting. And last year, there was a global breast cancer survey study in the pandemic era, which was conducted by the Harvard group. And I could feel the stark difference between these two societies and two continents. When Jennifer Bellon from Harvard group kept saying 1.8 gray as conventional fractionations, and Philip Putmans, the former president of ASTRO, responded that it is not conventional fractionation, but a historical fractionations. And 5-fraction schedule that after subsequently 5-fraction schedule that approaches the limits of whole breast hypofractions, which called ultra hypofractionations, was tested in another 2 consecutive trials. And the first long-term safety result of FAST trial was reported previously, and 5-year safety and treatment outcome data of FAST forward were published recently. The 5-year efficacy and late luminal tissue effect results of FAST forward was published in 2020 Lancet paper, and it turns out that 26 gray delivered in 1 week showed similar local recurrence rate, and the toxicity profiles compared with 40 gray in 15 fractions was similar. But in 27 gray in 5 fractions had a higher toxicity profiles than 40 gray in 15 fractions. And based on this result, UK amended the national consensus to endorse this regimen as standard of care instead of 15 fraction regimens in last October. And this year, St. Gallen panel discussion was held in March 2021, and which is published this year. And you can get a sense of current international expert consensus on hypofractionations. According to this paper, 64% of the panelists said there is no restrictions in the use of hypofractionation radiation, even in regional node radiation, which is very progressive way. And 9 to 19% of panelists endorse use of ultra hypofractionation 5-fraction regimen. And interestingly, when the question was changed and asked specifically, they endorsed hypofractional radiation for PMRT in 90% and regional node radiation in 76%. So in line with the expansion of evidence about breast hypofractionations, Janssen Cancer Center have implemented 15 fraction UK Start B regimen in early 2010s and 5 fraction regimen last year. Before the 15 fraction regimen, we used the conventional fractionation with sequential boost with 1.8 gray 5 fractions. And when you look at history again, after these randomized trial, there was 3 radiation omission trials, Uppsala BCSG, OCOG, and Milan 3. And once observations regarding relapse patterns after breast conservation surgery without radiations emerged, investigations began into partial breast irradiations. And findings from these studies without radiations, they reported the majority of local recurrences after lumpectomy were at or near tumor bed. And because when irradiated volume of breast became smaller, much higher fraction dose would be tolerable, and even fewer fractions of retreatment can be applicable to select patients. And I summarized all the landmark trials of APBI of different techniques in this table. And building on the lessons learned from 1980s randomized trials, these are modern trials that shows the advantage of APBI. The first and the longest history of APBI was primarily multi-catheter brachytherapy, which was stemmed from Jag Astro and the Hungary group mainly did this approach. And they had a longest report of randomized trial that they showed the similar local recurrence rate and less late toxicity in APBI arm. And after that, subsequently in Canada, the RAPID trial was conducted to test to using the 3D conformal external beam radiations. And these regimens used 10 fractions BIU regimen. And in NSABP B39, they use also 3D conformal radiation and also a single entry balloon brachytherapy mammocyte device. And in Italy, there was randomized trial to compare using the IMRT-based APBI. And also there was electron-based IORT trial or low kilovoltage-based IORT trial, but I'm not gonna touch this topic, IORT trial, in this today's talk. So final result of these three large phase 3 randomized trial after Jag Astro were published last year in Lancet and JCO. And in RAPID trial and NSABP B39 trials, which included several thousands cases, showed successful results despite some caveats. In RAPID trial, they showed similar local recurrence, but more late toxicity in APBI. And the authors speculated that BID regimen was the main reason. And in NSABP B39 trial, the APBI was associated with inferior local recurrence. But the author concluded that 10-year IBTR was less than 1%, and the absolute difference was very minimal. And in APBI IMRT Florence trial was most impressive one, which was published in JCO last year by Ikromiatini group. And this was a practice-changing trial that 30 gray in 5 fractions to partial breast and every other day using IMRT showed similar local control rate while decreased toxicity and better cosmesis than conventional whole breast radiations. So over the last 3 decades, as I showed previously, various techniques have been introduced with promising clinical outcomes. And however, because of relatively small breast volume in Asian women, especially in East Asian and Korea women, most radiation oncologists in Korea has felt uncomfortable to apply these APBI technique with conventional techniques, which was proven in Western countries. So I'm working at Gangnam Severance right now, and this hospital is one of the top accrual hospital of target intraoperative radiation trial in the world. And this case is my patients that who enrolled the target B trial and got IORT boost 20 grades and hypofractionation whole breast radiation. And as you can see here, very severe most discomation and skin reaction was occurred, and I still feel uncomfortable to see to apply these applicator to small size breast patients in Korea. So among various options, Yonsei Cancer Center implement the CyberKnife-based stereotactic PBI in highly selected women in 30 gray in 5 fractions in every other day, which was similar, exactly same as Ikromiatini's regimen of APBI IMRT Florence trial. And the preliminary result was published in 2020. And as you can see here, we are highly selecting the patients based on the ASTRO guideline, which was update guideline and only 6 to 10% of patients was suitable for APBI and provided with this technique. In the preliminary results, we observed almost no skin reactions within 1 year after stereotactic PBI, and we followed up until 2 years and still very confident to the skin status. And considering the skin thickness is known for its relationship with palpable induration, we measured the skin thickness using the follow-up ultrasound examinations, and we observed the change in skin thickness in PBI appears to be limited to the tumor bed, in contrast to the diffuse skin thickening observed after whole breast radiations, which means that PBI group had a less palpable indurations in a very early experience in our hospital. So in our daily practice, 15 fraction regimen are still the most commonly used schedule, and last year we started to use 5 fraction whole breast regimen or a fast 4 regimen or 30 gray 5 fraction every other day regimen of 8 PBI using CyberKnife is cautiously used about 2 out of 10 patients. So let's shift gears and move on to the next topic. And in a high-risk patients, we all, as you know, there were British Columbia trials and DBCG 82P and 82C trials, and comprehensive local regional radiations, including all the regional nodes. Post-mastectomy radiation was proven to increase overall survival in these old clinical trials, and subsequently, even in early stage patients, N0 with even in N0 and high risk features patients, were benefit by adding comprehensive local regional radiations, and ERTC and MA20 and DBCG IMN trial was reported after 2010. And 2015, we all, as you all know, that first high-level evidence was published supporting, including the IMN change in the radiation field. And the long-term data of ERTC trial was reported last year. We show both of trials showed the significant disease-free survival benefit with borderline overall survival benefit by adding comprehensive regional node radiations. However, at the same time, it seems clear that radiation exposures to red hot inevitably increase the subsequent cardiac disease, as Sarah Darby first reported in 2013. And as you know, in Sarah Darby's paper, they reconstructed virtually the planning from the old 2D-based trial, and they showed the first dose response report, and we can see there's no safety zone and no threshold that radiation is safe. And after that, in 2017, the Dutch group also showed a similar result, and the second dose response report with modern data and with all based on 3-dimensional dose distributions. And also this year, we also published the similar result based in Asian and in Korean women, and also from 3-dimensional radiation therapy planning. And as you can see here, in high-risk patient, cardiac who had a high cardiac baseline risk or low baseline risk, both groups has similar dose-response relationship, and which is confirmed also in Asian groups, that which means that effort should be needed in all patients to maximize cardiac sparing. So in our institution, we have adopted all available devices or techniques for maximal heart sparing as possible. So in the past, we used tangent-based technique or reverse hockey stick technique using individual custom-made bolus. And in 2013, DIBH was implemented with APCHES devices, which was manufactured from Japanese company. And in 2015, we implement VMAT and prone positions breast RT. And in 2018, as I mentioned, we started PBI, which is also had a lot of advantage to spare HUT from the radiation exposure. And in 2020, we also implemented Cpap technique as an alternative of DIBH. And we can, with advent of systemic agents and screening program, long-term survival has become uncommon. As you can see in our previous report, even in the same T1, T2, N1 breast cancer patients, patients had a different prognosis. And the survival of this N1 patients improved over time, and the local regional recurrence dropped dramatically over time, even in the same T and N stage. So accordingly, radiation-related toxicity is becoming more and more important for patient care. So these are the well-known toxicity caused by radiation, breast radiations. And in contrast to head and neck cancer and lung cancer, the target volume methods for breast cancer are still mostly based on conventional field-based two-dimensional radiation techniques. However, the ASTRO insisted and stated that volume-based and individual treatment planning is the way to go in modern future radiotherapy. And we all know that in 2008, there was a RTOG guideline to contour in a breast cancer RT, but in 2015, international expert consensus recommend the modern breast RT should be based on vessel-based anatomical definition of target volumes. And the reason that this guideline was published was especially in early stage patients, the modified or more smaller or individual vessel-based RT volume should be applied. And considering that actual local regional recurrence risk, we previously conducted target volume validation studies and suggested that ASTRO guideline consensus CTV was sufficient to cover early stage cases mostly. But in higher nodal stage cases, individual modification and individual correction should be required based on individual patient data. And whatever the reason, use of IMRT is increasing over time in Korea, especially in Korea in breast cancer. And however, according to dummy run study, there are extremely large variations in target volume delineation and planning results among physicians and hospitals. For example, in a same patient, you can see the wide variation in target volume delineation, and mean HUT dose and lung V20% had a huge inter-hospital variation from 3 grade to 24 grade and 5% to 60%. So we show that IMRT experience matters, and over time, we have improved the planning quality and dropped the mean HUT dose. And currently, we conducted the planning study and reported this year that mean HUT dose below 2 grade can be achieved with VMAT plan when it combined with Cpap based respiratory motion control, which is as good as the proton beam therapy. So in this study, proton and 3D planning and VMAT with or without Cpap was conducted. And then we assessed the clinical benefit of combining VMAT and hypofractionation radiation, considering the radiation-related toxicity and local regional recurrence rate. And this paper was published in International Journal of Cancer this year. From 2010 to 2017, as I mentioned, from conventional fractionation, we moved to the hypofractionation, and in 2014, we started to use VMAT. So we can divide the patient into 3 groups, conventional 3D and hypofraction 3D and hypofraction VMAT. And as here is the representative of the dose scheme and the tumor bed boost dose. And in this study, we look at the acute and subacute toxicity, mainly the skin reactions. And late toxicity were we included radiation pneumonitis, symptomatic pneumonitis, and lymphedema, and hypothyroidism, which was not a common toxicity profile in a breast cancer study. And we also include cardiac toxicities. Because patients were not randomly assigned to each treatment groups, IPTW pairwise comparison analysis was used to minimize the effect of potential confounders and selection biases. And this is the main finding of this study. And as you can see on the first line, both hypo 3D and hypo VMAT were associated with lower risk of acute and subacute toxicity, which makes sense that less skin toxicity were seen and less induration was seen in hypofraction 40 gray 15 fraction regimen. And similar results were seen in late toxicities, which were consistent with DBCG hypo trial or UK START B trial. And when we compare the 3D and VMAT in the same hypofractionation setting, the skin reaction and radiation pneumonitis was significantly reduced by the use of VMAT, and which also makes very sense that VMAT improved dose homogeneity, and which led to less acute and subacute toxicity, and VMAT was showed a less 320 and 330 profile, long dose profiles, so which led to clinical less radiation pneumonitis. And interestingly, local regional recurrence rates and lymphedema rates were not differed by fractionations nor treatment modality. So. And in a subgroup analysis, according to regional radiations, showed that the advantage of addition of VMAT into this hypofractionation became more prominent in patients who underwent regional radiation, which also made very sense. And although we think the follow-up time is not sufficient to see whether second primary cancer increased by use of IMRT at this time point, we did not see the increased risk of second malignancy by use of VMAT in our cohort, which is consistent with the findings from the MD Anderson that compared 3D versus breast IMRT in a NCDB database published in 2020 Cancer Journal. And as field-based conventional tangent field radiation has been used for breast cancer, we don't have breast cancer specific dose constraint for breast IMRT. We adopted a lung cancer specific dose constraint for breast IMRT. So for this reason, we have tried to find a breast cancer specific lung dose constraint using approximately 2,000 patients in 3-dimensional dose volume analysis. And the main result was each lateral lung 330 gray was the most important parameter. And we proposed that this parameter can be the long dose constraint in breast RT. And we have never considered thyroid as OAR and put specific dose constraint in breast planning. Although thyroid was shielded, occasionally shielded along with esophagus in field-based 3D CRT. And like a lung study before this slide, we have assessed the incidence of hypothyroidism in 4,000 women who treated with breast radiations. And in this study, DVH analysis, we can find that the hypothyroidism risk was dichotomized by several thresholds, and further study to build the anti-CP model and dose constraint are underway. And regional lymph node radiation is a well-known risk factor for lymphedema and breast cancer. And we also reported lymphedema study using 7,000 patients and in Annals of Surgery recently. In the same line with the lung and thyroid, we try to find the breast cancer specific dose constraint for preventing lymphedema. And as proposed by Jeffrey Gross in published in Red Journal 3 years ago, axillary lateral thoracic artery junction was contoured as potential OAR for lymphedema in more than 1,000 patients manually. And in this preliminary analysis, lymphedema risk also can be dichotomized in certain dose level in this region. So we believe that in breast IMRT, the breast cancer specific dose constraint is essential to use. In summary, contouring of all possible OAR and delineation of individual target volume, considering anatomy and characteristic are utmost important in the future breast radiation as toxicity and quality of life are becoming more important as long-term survivors become commonplace. To improve the quality of target contouring, we have developed the deep learning-based auto-contouring model and reported these in Green Journal last year and Radiation Oncology recently. And in this clip, left side is the manual contours that I contour, and right side is the deep learning-based model generated auto contours. And we are currently using this auto segmentation tool in the clinic. And in this process, CT image, when CT image were acquired from patients, it automatically sent to the workstations, and auto contours were generated automatically and send out to the radiation PACS server in our system. And finally, the physicians are correcting or adjusting all contour considering the patient's individual characteristics, including the anatomy and the pathology. And this is just an example of breast radiation contours of my patient. And you can see the generated contours in the left side. And this is really the great tool that improved the quality of and maintain the quality consistently and efficiently, saving the time. And wrapping up today's talk, de-escalation strategies such as hypofractionations and ultra hypofractionation and partial breast irradiation are inevitable ongoing standard of care practice in early breast cancer. And every effort to minimize the radiation cardiac exposure are critically important to optimize the therapeutic window in the modern era, especially the risk of local regional recurrence is below 3 to 5%. Reasonably low in the modern era. And initially, breast IMRT was focused to reduce the acute toxicity like skin reaction, but recent efforts are focused into cardiac sparing while maintaining improved dose homogeneity. However, breast IMRT vary in sophistications, and we all recognize that there are wide interphysician discrepancies regarding dose volume profiles in breast plan. And our experience regarding breast IMRT was shown to reduce the acute and late toxicities with good local regional control. However, but high-level evidence and quality assurance programs seems essential before widespread adoption of breast IMRT. And furthermore, every nation has different health insurance system, and cost effectiveness issue could be another issue. I want to give all the credits of today's talk to our senior members, and they have put their best efforts to pave the way for these wonderful breast radiation treatment in Yonsei from scratch. Thank you.
Thank you, Dr. Chang, for your remarkable and very informative speech, as always. Now everyone sees why Dr. Chang is such a celebrity, and I have a feeling that his fandom has reached Asia from this moment. Just kidding. Next, I would like to introduce the expert panels. Before answering the question, there are a couple of questions on the window. But first, I will introduce the panelists first. Dr. Yongbei Kim from Yonsei Cancer Center, Korea. Dr. Jihyun Chang from Seoul National University Hospital, Korea. Dr. Rima Pathak from Tata Memorial Center, India. And Dr. Jiro Kawamori from St. Luke's International Hospital, Japan. I would like to thank the panelists from these three countries for willingly volunteering to attend today, and also would like to apologize for causing trouble with the last-minute notice on how today's paneling will proceed. For everyone's information, the panelists will take turns to make some comments or ask questions first in order to earn some time for everyone to think of questions from the floor. Does anyone from the panel have questions or comments to make before we go on to the questions from the floor?
Hi, good evening, everyone. I'm Dr. Rima Pathak here. And I agree with Dr. Lee that it was a wonderful presentation. I also enjoyed all the latest advances that were shown in your presentation, Dr. Chang. Now my question to you is that, and I think one of the attendees have also asked that question, do you always use free breathing CTs or deep inspiratory breath hold when you're treating patients with IMRT? What has been your practice? And then I shall comment on what we do over here in India.
Thank you for great questions. And so we have used DIBH technique for more than 7 years, and and about 95%, it's just my guess, and patients are tolerable to these techniques. And the problem, the main issue of this technique was the time and labor intensive process. So more time is needed to treat with this technique. So, and then we moved to the Cpap technique, which is very novel, innovative technique published in Red Journal, which was originally published, which is the tool that used in sleep apnea, but the Israel group, Tel Aviv group, they show the potential for use in a breast radiation and lung SBRT. So we adopted the Cpap technique, and now all the left-sided breast cancer are simulated with both free and Cpap based technique, motion control. And if the patient is not tolerable to Cpap technique, we consider to apply the DIBH technique. And that's the current policy of our institutions. And but we are facing more and more patients, right side patients had much higher mean heart dose than left side, because it's like a very awkward situation. So then we are thinking that applying these also DIBH or Cpap technique in a right breast with a regional node patients, but not currently. We are not routinely applying these techniques, but that's our practice.
Right. So I'm not sure about what the other panelists practice, but at Tata Hospital for some time we've been trying to use sparingly only use IMRT, maybe for about 5 to 7% of our current patient load. And we try and do DIBH for most of them, but for patients that are not suitable for DIBH or patients that cannot do DIBH, then we end up treating them with free breathing. And in some patients, yes, we've also noticed higher heart doses. And now my one question was that for Cpap, how much time does it take? Additional time as compared to treating in free breathing, just as a comment.
So in DIBH technique, we have to hold the breath for like 30 seconds, and then there is a pause for 30 seconds again. So it doubled the times and like double or triple the time. But in Cpap technique, it's the continuously positive airway pressures. So beam on time is exactly identical with the free breathing techniques. And that's the main advantage to apply this in a very large volume hospital like Jan said, yeah. But if you have a so I don't think Cpap is much better than DIBH technique, conventional technique, but both techniques has a pros and cons, and patients had a if the patients feel comfortable for one technique, that's very good option. So as many as options that we have, that's very good for patients. So I think, yeah, that's my answer.
Thank you.
To carry on, I think it would be nice to listen to other panelists' practice, whether they use DIBH and how much they use it. Dr. Chang from Jihan Chang from Seoul National University Hospital. There are two Dr. Changs today. So how do you practice?
Can I share my slide now?
Sorry?
Can I share my slide?
Sure.
Oh, yes, please.
Hello, my name is Dr. Jian Zhang, and I'm working at Seoul National University Hospital in Korea. And thanks for having me as a panelist. I was asked to give a talk yesterday, so I briefly prepared a couple of slides about hypofractionation and APBI protocol in Seoul National. In Seoul National, we are treating all breast cancer patients with hypofractionation, including DCIS and post-mastectomy cases. Our dose fractionation scheme is as shown below. 40.5 gray in 15 fractions or 43.2 gray in 60 fractions for whole breast or chest wall irradiation, and 9.6 gray in 4 fractions for routine tumor bed boost. If the tumor has some risk factors, the boost dose could be escalated. And regarding APBI, this table shows the general indication for APBI in Seoul National with indications that were determined suitable for APBI by Astro. Indications of Seoul National is very similar to Astro's suitable group, but is more strict in terms of biological subtypes or histology grade. The APBI in Seoul National is MR-guided APBI using V-ray. CTV is set as tumor bed and 1 to 2 centimeter margin is given for PTV expansion, and total of 38.5 gray in 10 fraction are given daily. The advantage of MR-guided APBI is that you can see the surgical cavities during the treatment. You can enhance the treatment accuracy by checking the changes of volume and location of seroma. I didn't include a slide here, but our institution published the result that the seromas exhibit shrinkage over the course of PBI, and the frequent monitoring of volume change could be helpful in decision-making for adaptive planning. And recently, our institution, Professor Kyung Shin in our institution published the results of APBI experience with median follow-up of 35 months. In this favorable group who received APBI, 2 patients experienced ipsilateral breast recurrence. And we focused on toxicities with this once per day treatments, as twice per day regimen has raised concerns about increased rates of late toxicities in randomized trials, as Dr. Jisuk Chang mentioned in his talk. As a result, acute and late toxicities were less frequent in the patient treated with APBI, showing that once per day, APBI afforded excellent local regional control and fewer toxicities compared with accelerated whole breast irradiation. This is my last slide, thank you. And as breathing control, we are using free breathing scheme in all breast cancer patients, and we are preparing to apply Cpap as in Yonsei, and it is prohibited right now by regulation. So we are trying to open a clinical trial with Dongnam Gijang Cancer Center. Thank you.
Thank you very much. Wow, I didn't know you prepared the slides. Thank you very much. Dr. Kawamori, how do you practice DIBH technique in your center?
Thank you. In Japan, DIBH is last year many cases practice, and our hospital is a left side patient is commonly used DIBH. You are to doctor with any question. APBI cases, PTB described to tumor but the cavity or clipping, okay? PTB cavity describes small cavity or surgical clip, or which is this? Okay, question, okay?
So is that questions? Is that question is about surgical clipping or tumor cavity visualizations? Yeah, yes, that's also very important issues, and we all knew that target, especially tumor cavity volume delineation, there are a lot of wide variations in interphysician. So we are using surgical clip, at least 4 or 3 surgical clips to mark the lesions, but we are not feeling comfortable that we are covering all the cavity. So we are in our practice. I think the communication with the counterpart breast surgeons are essentials to delineate the tumor cavity. And according to the papers, the addition of the breast MRI will compensate the limitation of the breast CT simulation. So I think Jian Chang from Seoul National University had a more experience with using a breast MRI in this setting, and also using other like a biodegradable like radiopaque hydrogel in a tumor cavity or some other devices. There are a lot of papers that try to improve the visualization of tumor cavity. But currently in our hospital, we are using 4 clips. That's my answer.
Doctor, and one more question. decided to indication the IMRT for breast cancer. And do you think is a second cancer risk in younger patients? How?
That's also very important questions. And so that was for initially that was the main concern that applied IMRT especially in young patients, but in our practice we don't have any restrictions according to the age, and but there is a specific dose constraint that we contour all the contralateral breast tissues, and then try to limit less than 3 gray. And which is really similar to the 3D technique. And as I showed in our previous presentations, our report said until now, the similar secondary malignancy rate was reported, and this was consistent with MD Anderson report.
Thank you.
Yeah. But we need more data and longer follow-up. So yeah, you're right, yeah.
Thank you. When I was looking at the questions from the audience, there are many questions regarding the IBH, and one of them is, what do you think with the idea of using the IBH for right breast to reduce liver dose?
So liver dose, I never thought about that, but there was a very interesting poll that whether physicians used DIBH or this kind of technique in a right side breast. And recently there was a poll in the United States in MedNet, and 1/3 of hospitals already they use DIBH in a right breast to reduce the hot dose, because even in a right side breast cancer, the right coronary artery is near the right side breast, and you can see sometimes the heart is in a midline. So so considering the maximal heart sparing, there's no reason that we don't apply the DIBH in a right side breast. And already in America they use DIBH in right side breast in 1/3 of hospitals.
Thank you. For another question from Dr. Yu Tang, he commented, thank you. Thanks for the impressive speech. My question is, when using the IBH technique for breast cancer patients receiving RNI, how do you fix the patients, especially the supraclavicular region?
That's also very interesting point. Very interesting point. And usually we are in the past we used breastboard with some degree of like this degree of a table, a couch. But in an IMRT plan, we used the S plate to immobilize the neck area, and with that we feel confidence to that. So we are using S plate in a regional node radiation setting. So this is also very interesting question. So I want to also ask to other panelists, and how do you manage that similar positions?
Hi, so I'm Rima here again. At our institute, we use vacuum bags if we are treating patients with IMRT, whether it is on the left side or the right side, for the immobilization. And we see to it that the entire arm structures, when the arm is overhead and the entire head is within the vacuum bag, and that helps with immobilization. When some patients do not produce immobilization despite this vacuum bag, we also take chin to elbow distance when the patient has been immobilized, and that sort of helps in most cases. There are some patients when doing deep inspiration, they tend to change the neck position while they're taking that making that effort for that deep breath. And we've noticed that especially with DIBH patients. But if it is free breathing, then that's not been a major issue so far.
Thank you.
Any other comments on the issue from the panels? Okay, then we'll move on to the next question. There were some questions about the regional nodal irradiation, and Dr. Chang has already answered about the internal mammary nodal irradiation. So I will pass on. And another good question on the target volume was by Dr. Fang Chen. What is your practice of the irradiate target column for locally advanced breast cancer post-neoadjuvant chemotherapy?
So maybe I think there is a typo that target volume for locally advanced breast cancer after neoadjuvant chemotherapy.
Yes.
And I don't think the target volume is different according to regardless of the the use of neoadjuvant chemotherapy. So so it's all because it's all removed, and we are treating the microscopic disease, and we are contouring first based on the vessel-based Eastro guideline, CTV. And so first we try to decide which nodal basin will cover by the radiations. So sometimes axillary level 1 is compared when the axillary node dissection is completed and there is a minimal nodal burden. And sometimes we used very small regional Supraclavicular volume based on Astro, which in a early stage high-risk patients. So it's all individual based, and we have to consider what was the initial tumor burden and locations, and we have to try to cover all that pre-chemo volume, and then that's my answer.
Thank you. There are other questions on the target volume. Dr. Endang Nuriyardi has asked, "Dear Dr. Chang, thank you for your presentation. I want to ask, in your hospital, in PMRT patient, when do you omit radiation for level 1 and level 2 axillary lymph nodes?"
That's a very tricky question and challenging questions. And even in the same hospital, and Dr. Kim, Yongbaek Kim, my senior professor, and I had a little discrepancy in covering the level 1 and level 2. And so the point is whether axillary, so the point, we have to consider the regional recurrence risk first. And then also we have to, at the same time, we have to consider the lymphedema risk. So we have to balance we have to try to balance the risk benefit of including the regional node. So I believe less surgery and more radiation is beneficial to patients in to both control the axillary and improve the patient quality of life. But if the surgeons dissected a large number of lymph nodes, I occasionally omit axillary 1 or 2 in a target volume. Yeah.
Do you have any guides on the number of removed lymph nodes on that decision?
So our group published the lymphedema predicting nomogram, and we had that tool in a web-based. So after we predict the patient's lymphedema risk first, and then and then we discuss with the patient with that the predicted risk that you have a lymphedema risk like this, and if we cover all this radiation with this radiation, you have increased risk of lymphedema, and we made decision case by case. Yeah. So there's no actual threshold or yeah.
So very multifactorial. Yeah. Okay, last question about target volume from the audience. Dr. Guang Yingzhu asked, hi, is it necessary to irradiate the drainage wound in post-operative radiotherapy for patient with breast conservation? Thanks.
That's also very, very great questions. And I've never thought about that before, but recently there is a very nice paper by Philip Putman about these questions. So maybe the audience should search that paper, maybe not an original article, but a letter that that author insisted that inclusion of the drainage wound is very necessary to in breast conservation radiations. So I agree with that opinion, and that's very good questions.
Okay, thank you. I'm amazed by how Dr. Chang can answer every question. Okay, so the next theme, before we go on to the next theme, from the panelists, any comments about the target volumes covered until now? Okay, we can go on, or Dr. Patak?
Yeah, so in our study, so similar to the study that was conducted by Dr. Jang, looking at the local as well as regional recurrences, we had a study of consecutive 100 patients, and we saw that a lot of patients failed in the interpectoral and over the pectoralis in locally advanced breast cancers. And that is why for all LABCs, despite the fact that the chest wall muscles and pectorals were not involved at baseline, we've modified the ESTRO guideline for our institution, and we include both pectoralis major and minor in our contouring. So that is one difference we have maintained as compared to the recommended guidelines. So that is that. But I do agree that in terms of target volume delineation for tumor bed, it becomes very difficult, especially in oncoplasty cases. Not type 1 oncoplasty as much, but type 2 oncoplasty, where your clips really don't guide you enough. And those are the patients where the hydrogel may be more beneficial, though we at our institute do not have much experience with that.
Thank you. Now, the next question is mainly about the indications of hypofractionation. So Dr. Fang Chen asked, what's the indication of hypofractionated RT in breast cancer in your institution? Early stage breast cancer post breast conservative therapy, or can be offered to locally advanced stage of breast cancer patients post mastectomy, such as T4N2/3 disease?
So based on the evidence and data, there are only one randomized trial from China that's supporting the use of hypofractionation in locally advanced setting, in mastectomy setting. And as I showed in my presentation, there is no radiobiological reason that we don't have the expected outcome can be different by hypofraction in locally advanced setting. So in my practice, we are using hypofraction regardless of stage, and we don't have any restrictions. But there is limited evidence compared with early stage breast cancer. So like I think some believe it is okay, but others believe still worried about the hypofraction is not currently not standard in a locally advanced setting. So we still need some more data.
Okay, thank you. There is another question about the indication of hypofractionated RT. Any concerns with hypo or ultra hypofractionation on reconstructed breast?
Reconstruction is also a huge issue, topic. So last month I had a presentation about hypofractionation in reconstruction settings. So if you want to see the talk, the clip, I posted in a Twitter, so you can see that if you want to see the whole details. But in our experience, we use hypofractionation in reconstruction setting for like more than 5 years, and with VMAT. And we in the previous studies, we found that the maximal point dose in a reconstruction area is correlated to the reconstruction complications. So so in that reason, using the hypofractionation and VMAT, we believe that could reduce the complications. And we are currently conducting the prospective study to evaluate multi-center prospective study to evaluate the hypofractionation in a reconstruction study. So maybe in the near future, we can publish that data. And in United States, RT-CHOM trial is underway. So we can, in the near future, maybe we will get the answer.
Thank you. I also have a question. Sorry?
What about ultra hypofractionation?
No. I don't. There's no mature data yet. So we have to wait for fast forward lymphatic studies in the near future, and I don't think we don't have enough data to use that in a daily practice.
And when you mean reconstructed breast, do you mean autologous reconstruction or implant based?
Autologous reconstructions, we don't have to fear about giving radiation in this setting, because in a MROC study, consortium study, there is a great evidence that radiation did not really increase the reconstruction complication or cosmesis outcome in an autologous reconstruction. But in a implant-based or expanded two-stage-based reconstructions, there is like radiation can double or triple the reconstruction complications. So we have to concern that. And I believe that hypofraction and conventional fractionation both increase the risk, but the data should be mature, and more data is needed.
I also have a question. How would you sequence the oncologic surgery and the reconstruction and the hypofractionated RT?
So you mean in a breast reconstruction setting? We conducted a patterns of care study and published this year, and in all hospitals, all have a different approaches. So some hospital preferred autologous or one stage or two stage, or so. I think there's no gold standard and no one size fit all approach in this setting. So and in our hospital, we prefer two-stage based tissue expander, and after a tissue expander, and we did a hypofractionation, and after that, we need to wait 6 months and then give a second stage delayed reconstructions. But every hospital has a different approach, and
okay, thank you. Now the last theme of questions was about ultra hypofractionation. So mainly the questions were what indication you would have for ultra hypofractionation?
So as like eligibility criteria in a fast-forward trial. So early breast cancer, which is not after we select a partial breast irradiation candidate first, and then who are not regional node candidate, and then and whole breast radiation population, we consider ultra hypofractionation regimen in these patients.
Thank you.
I have a question. So do you have any experience with single fraction radiation to the breast?
No, never. But there is a report from a Duke study at Duke University. They performed a single fraction 20 gray SBRT to the breast before surgery, and yeah. So,
are you planning on going up to 1 fraction at all, or 5 is where you call it?
So I think there is a practicing change, maybe possible practicing changing in a near future that there's a randomized trial in Germany that comparing the pre-operative radiation versus post-operative radiations. Maybe 10 years later, the result will come, but if the neoadjuvant setting, we can think about giving a radiation like single fraction, 5 fraction, but that's all hypothesis. So,
and yeah. One last question from my side. Either you or anyone from the panelists have any experience in treating patients of breast cancer with protons?
I have a experience of planning studies. So I have a preconceived notions that proton is too much in a breast radiation before, but after conducting a dosimetric planning study, comparing the VMAT and proton, and I feel proton is like superb in sparing the hot and contralateral breast. In a hot, they can a proton can minimize the hot dose almost like a 0, and in a contralateral breast almost 0. But the clinical relevance is not elucidated yet. So we are waiting for 2 trials in which is one is a RedCom study, which is conducted in America, comparing proton and photon, maybe 10 years later. And in Europe, DBCG proton trial is also initiated last year. So maybe 10 years later, we will know the answer.
Okay, so we are slightly over the scheduled time, but I'll just give 2 more questions, which is on the bulletin. Do you still practice scar boost during PMRT? If yes, what are your indications? Thank you. And another question is by Dr. I Ding Ting. In your opinion, which technique, Cpap or DIPH, is more readily acceptable and easier to implement for heart sparing in a small and resource-limited clinic?
First question is about the scar boost, and we don't use a routine scar boost in a mastectomy cases. And in our practice practice pattern survey, there's a very wide variation in across the hospitals. And there's a very nice paper from Harvard that chest wall boost did not correlate it to the improved local control in a mastectomy setting, which was published this year in a Red Journal, and it significantly increased the reconstruction complications. So we have to be cautious about routine use of chest wall boost or scar boost in a mastectomy setting, especially when patient had a reconstruction. And the second question is about, sorry. Cpap and DIBH, yeah. So in a resource limiting area, I think Cpap is way better than DIBH. And there is because it's very easy to implement, and if the patients get used to this, and so it's very super easy to use in a clinic. But more evidence in a DI gauge. So yeah. So Shiwon, I think your microphone is muted.
Okay. So one last question. What do you do for scars extending to the contralateral breast?
Sorry?
The scars extending to the contralateral breast. What do you do for the scar boost?
I've never had the patient like this, so maybe other panelists can help me.
Actually, if it went to the contralateral breast, I didn't include the contralateral breast because I thought it wasn't clinically significant for clinical outcome. Okay, I think that's about it. If there are no more questions or comments, there is one announcement I would like to make. The 7th webinar will be organized by the Sri Lanka College of Oncologists, and it's scheduled on June 22nd, Tuesday, 3:30 p.m. on Sri Lankan and Indian time. And the topic is on organ preservation with radical radiotherapy in muscle invasive bladder cancer, recent advances and future prospects. Please keep your eyes and ears for future announcements. Okay, so thank you everyone. And I will close the webinar by thanking everyone for your invaluable presence today. And we'll be looking forward to meeting you all on the next webinar. Thank you.
이시원 선생님 수고하셨습니다.
감사합니다.
네.
Thank you.
다 수고하셨습니다.
고맙습니다.
Can we take the photo?
And the panelists, thank you very much.
Okay, we can take another photo.
Help to take the photo. Please, everybody,
Okay,
can you open
for
your
all
camera?
panelists.
You panelist, I can go off.
Okay, I will take photo in 3, 2, and 1. Okay, maybe one more photo. Okay, maybe one more photo in 3, 2, and 1. Okay, perfect.
Okay, thank you.
Thank you.
Thank you, everyone.
Thank you so much.
Congratulations, Dr.
Everybody.
Great webinar.
Congratulations.
Congratulations. Thank you.
Thank you.
Thank you, everyone. Bye.
Thank you, Lee, and thank you, the whole team.
Yeah, I didn't see her. Yeah. Bye.
Hi, Dr. Bili Maga.
I see you earlier. Nice to see you.
Bye. Thank you.
Bye-bye.
Nice to see you, everybody. Yesterday we met also, and
Bye,
today
Dr. Chang.
tomorrow we meet again.
Yeah.
Bye. Bye, Dr. Kim.
Bye.
Hey, C1.
Yes.
Bye.
Very good.
Bye,
good
Prof. Bye, Prof.
Thank you very much.
Very nice.
Dr. Chang did everything.
Yes, Dr. Chang, thank you.
Yes. Thank you, Dr. Tamaki, for helping so much. Dr. Mayang and Dr.
Thank you.
Thank you.
Congratulations.
Thank you very much.
Okay.
Have a nice evening, nice afternoon.
Yes, you too. Bye-bye.
Bye-bye.
Thank
Bye.
you.
Maybe I will end the webinar now. Thank you very
Thank
much.
you, Nico.
Thank you.